Good afternoon, everyone from the audience. It's my great pleasure to start a second liver talks from Hepato Pernambuco 2020. In this, we all talk about the NAFLD and pathology of this disease. It's my great pleasure to introduce my close friend, Professor Vlad Ratziu. He's a professor of hepatology at the Université Pierre and Marie Curie and the Hospital Pitié Saint-Pétier Medical School in Paris, and Professor Pierre Bedossa, Emeritus Professor of Pathology of University of Paris. Professor Vlad Ratziu will talk for us NAFLD, new definition, and Professor Pierre Bedossa will present Nash, why liver biopsy is important. From this round table, is my pleasure also to have Professor Cláudia Oliveira. She's a professor of gastroenterology in the University of São Paulo, and also Professor Venâncio Alves. He is a full professor of pathology from the University of São Paulo. Good afternoon for everyone in Brazil, and bonjour for my friends from Paris. Now, I'd like to invite the Professor Vlad Ratziu to present your talks. And I'd like to apologize for 2 minutes. I'd like to speak Portuguese to mention some things to our audience in Brazil. Pessoal, bom dia, boa tarde a todos, como eu já falei. Eu gostaria de lembrar vocês que as perguntas podem ser feitas pelo Q&A. Se já puder fazer em inglês, seria melhor. Se não, a gente vai traduzir para vocês. Não deixem de participar nas perguntas. E também lembrando que amanhã nós temos uma nova palestra, amanhã não, dia 8, uma nova palestra, e que cada uma das palestras do Liver Talks e do Hepato Pernambuco tem um link especial. Tá? Nós também disponibilizamos, nesse momento de solidariedade, um QR Code para que nós pudéssemos manter as nossas ações que nós estamos fazendo aqui através do Instituto do Fígado de Transplante de Pernambuco. Eu vou voltar a falar um pouquinho em inglês e Vlad começa a iniciar. Okay, Vlad, I think could be start, but I'd like to present myself. I'm a full professor of gastroenterology from the University of Pernambuco, and also president of the Institute of Liver Study of Pernambuco in Brazil. Okay, Vlad, pleasure to have you here, and introduce your talks, please.
Thank you, Leila. It's always very good to see our Brazilian friends, and congratulations for always setting up this great meeting every year. I know it is a meeting that is really very well attended, and unfortunately this time is a very different situation, but I know you put a lot of effort in trying to still maintain the meeting and do it so that everybody can benefit from it. So congratulations for that. But I really hope it's going to be for a short time, and then we'll come back to physical presence and see each other again, because a lot of this is what these meetings are about. So the subject today is very interesting and a hot topic, and you asked me to present about the new classification of Nash. May I have my first slide? Can I move the slides myself? No. I will tell you. Yeah. So this is these slides were made actually. I was helped by Jacob George, which, as you know, is one of the best scholars in the field in liver diseases and in Nash in particular. He works in Australia, in Sydney, and he and Mohammed Islam were decided to take on this name change and trying to give the rationale for why we should change the name from NAFLD to MAFLD last year. And they have done a lot of this work, and I'm going to share with you the slides they have provided me with. There is clear advantages of having a name change, because what we already have now is not good enough, neither for the doctors nor for the patients. It's never good to define a disease based on what it is not, it's always better to say what the disease is about. And we now know that at least the largest majority of patients with non-alcoholic fatty liver disease, actually they have metabolic dysfunction. And that we know for sure, and they have insulin resistance and lipotoxicity. So why keep calling them non-alcoholic when we already identified what the root of the problem is, which is metabolic dysfunction? If we define a disease by the negative, it has a lot of implications, especially for the patients, but also it tells a lot about our confidence to identify a particular disease process. And I think that it's never good to give a definition by the negative, but it's better to say what it is. And you will see that this has also profound implications, because if you use an exclusionary diagnosis like non-something, it means that you implicitly recognize that this disease cannot exist together with another condition. And we all know that that's not true. A lot of people can have two different liver diseases together, and that's not a reason for not recognizing one or the other. So why would we proceed differently with NASH than we did with hepatitis C or alcoholic liver disease, where a mixed cause of liver disease was already acknowledged? And then the other thing is that in people's minds, when you say non-something, it means that it's not as important as when you are able to put a name on something in a positive way. And we will see this has very important implications in terms of funding and in terms of disease awareness as well. So next slide. So I think the time is ripe for trying to redefine the nosology of this disease, particularly since we keep talking about it for many, many years. You can see on this timeline here that as soon as the term NASH was coined, after a few teams in the world started working on this, it became clear that the name and the nosology have serious insufficiencies. And this was recognized formally already in 2002, when after one of the first NIH and ASLD workshops actually on NASH was organized, people started having doubts about whether this is the right and the correct name. And we're now 18 years later, and despite different attempts by leaders in the field to underline the insufficiencies of the traditional nomenclature, no real move has been made concretely towards changing that. And I think that's why now, 20 years or so later, it becomes important that some sort of international action is being taken. For example, and I almost forgot about this, we wrote a paper back in 2009, because that's when for the first time EASL had an official meeting, single topic dedicated to non-alcoholic steatohepatitis, and trying to come up with some sort of consensual ideas. That was before the guidelines, consensual ideas about these disease. And the proceedings of that conference, which was held in Italy, in Bologna, was published subsequently in the journal. And you can see that this is published here. And one of the things we said already at that time was that because of different reasons, including the fact that you can have two diseases at the same time, we should no longer use the exclusionary name, and we should start calling the disease for what it is, meaning a liver disease in relation with metabolic dysfunction. So this is nothing really new, and it tells you that people recognized long ago the need for a change that would bring the definition of the disease more in line with what we know about it. I think the time is ripe for trying to do that in a systematic way. And this is how it all started, the very first serious attempt, not just to complain about the insufficiency of the name, but trying to move forward and propose something different, was done by Jacob George and Mohamed Eslam in Sydney, where they contacted a group of individuals who have been working in the field for many years. And you can recognize here some of the names, including Pierre Bedossa's name here, and some other names you're very familiar with. These people here have been asked what would be the right name for a new disease, and they voted on different names, and then some of the more popular one were selected. Then there was a second round of voting, and this was all published in a very nice paper in Gastroenterology. And that paper is worth reading because one of the reasons the author said we need to change the name also is the heterogeneity of the disease. And in order to have a sort of an umbrella term that covers better all the different presentations, the traditional name would have to change. And that procedure ended up with the adoption of the name metabolic associated fatty liver disease, which is MAFLD, and which is why we're talking about this today. And that was voted unanimously by this panel of people here. It was a proposed consensus name, and and then subsequently the same authors published a new paper, this time in the Journal of Hepatology, in a new section that we have, which is called Expert Opinion. And that paper went one step further, next slide, trying to better explain the rationale, but also some of the challenging issues, next slide, that are associated with the name change. Now, one of the consequences of having a negative name is the lack of awareness of the disease and the lack of positive public health perception of this disease. You can see here that there are other circumstances where a negative name was adopted, and this is non-communicable diseases, NCDs here. And you can see on this graph the striking difference between HIV, which is defined positively by what it is, and non-communicable diseases, mainly diabetes, arterial hypertension, dyslipidemia, all these diseases that are not transmitted through infectious agents. And you can see the enormous discrepancies here between their burden in terms of public health in pale blue and the proportion of global health funding. And you can see that this is exactly inversely proportional to the significance of the disease. HIV has a very, hopefully very small proportion of global disability years of life, but has a very high share of global health funding, whereas all the other non-communicable diseases have a very, very low share of global health funding, and yet they are a major part of the healthcare burden for the patients and the society. And there are certainly many reasons for that, but one of the reasons is that not having a name that can carry the disease in people's minds in a positive way, in a recognizable way, in a way that attributes a cause to the disease, does not help in raising awareness and raising financial resources for that. Another important limitation of the current situation beyond this negative definition is the fact that we all know that although non-alcoholic should mean no consumption of alcohol, the reality is that a lot of people do consume alcohol. And so therefore, our definitions do not apply for the very, very large majority of patients in real world who kind of accumulate risk factors for liver diseases. And the problem with alcohol is that although for the longest time we thought that you only run into problems if you drink a lot of alcohol, what turns out to be from large epidemiological studies is that even small amounts of alcohol can be dangerous for some aspects of health, particularly for cancer. And you can see here that in fact, there is no real safe limit for alcohol use, and even small amounts of alcohol start already increase the risk. Even from 2 drinks a day, which is below the threshold for Nash, start increasing health risks. And if you look on the right part of the slide, you can see that in terms of measuring non-invasively the amount of fibrosis, well, even people that are considered moderate drinkers, not heavy drinkers, still have more fibrosis in the liver than those who don't drink at all. And that's also true to a lesser extent, but it's still significant for people who are light drinkers, as you can see on the slide here. So clearly, even if you drink below the threshold that we have set for the definition of Nash, which is 20 grams women, 30 grams men, even if you're below that, you might have an impact in terms of liver fibrosis. So therefore, it is very difficult to ignore the consumption of alcohol when you assess the diagnosis of a disease. Because if you say simply NASH or NAFLD, that means that implicitly you think the patient you think alcohol does not contribute at all to the patient's condition. And these data here tell you that actually they do, and it's not taken into account in the diagnosis. So if you call it non-alcoholic or alcoholic, then you don't fully take into account all the causes of liver disease in a given individual, particularly those that have mild or moderate amounts of alcohol consumed. Next one. And another example of that is here is how much alcohol is necessary to build up steatosis in the liver. And you can see that even starting 2 drinks a day, 14 drinks a week, there is a clear increase in the proportion of patients with hepatic steatosis versus those that don't drink at all. So even at very low amounts, 20 and 30, alcohol can contribute to steatosis. So therefore, calling these patients NASH, non-alcoholic, does not take into account the other factors for liver injury, in this case, small amounts of alcohol. So that's why the definition needs to change. Next slide. So that is one of the things that brought to this name change. Now, once you change a name, and you also need to make clear the diagnostic criteria, because it's not just changing an acronym. You need to define a little better. And I think this was why the paper in Journal of Hepatology becomes very important, because it was the first attempt to define non-invasively what this entity can be. And as you can see here, it is defined very simply. So first, you need to have steatosis. However you show it, either by imaging techniques or blood biomarkers, whatever. Once you have steatosis, if you have overweight or diabetes, then automatically you're talking about metabolic fatty liver. If you don't have overweight or obesity in green, if you don't have diabetes either, then you are normal weight. But you can still have metabolic fatty liver if you have 2 metabolic risk factors. And the metabolic risk factors are all listed here in the bullet point list. It is about waist circumference, so visceral adiposity. It is about hypertension. It is about dyslipidemia. It is about pre-diabetes, which you know is the stage before diabetes, like 10 years before. It is about having insulin sensitivity that's suboptimal, which you can measure with a HOMA model, glycemia with insulin, serum fasting insulin. So if you have at least 2 of these metabolic risk factors together with steatosis by ultrasound, then you have metabolic fatty liver disease. So this is very important because it defines in a very clear way, I believe, and very simply what the clinical diagnosis of MAFLD should be. Another important advance of the paper that was published in the Journal of Hepatology is trying to identify in people with cirrhosis what belongs to MAFLD. And you know that sometimes it's very easy, it's straightforward. Patients have suspected cirrhosis, you do a liver biopsy, you see steatosis or steatohepatitis. So it's straightforward, it's easy. But sometimes it's not, because as you all know, at that late cirrhotic stage, you sometimes can lose steatosis, you can lose the inflammatory lesions. So there's just fibrosis with nodules, and you don't see any of the signs of NASH. So how can you then be sure that the cirrhosis that you see in that patient is the result of long evolving and long-standing metabolic fatty liver? And the paper here describes in a very precise way the elements for that diagnosis. So when the typical histology of NASH, of steatohepatitis is lacking in a patient with cirrhosis, you can still attribute that cirrhosis to MAFLD if you have past or present evidence of metabolic risk factors, meaning the patient was overweight during his lifetime, he was diabetic during his lifetime, or all the other criteria that we have seen previously. And if you have also together with that, either another liver biopsy 5-10 years before who shows that there was steatohepatitis, or if you have historical documentation of steatosis by hepatic imaging, meaning you have an ultrasound from 5 years ago, the ultrasound said steatosis. Today, there's no more steatosis. However, the patient had it, so it's very probable that he lost steatosis and inflammation, as it can be seen in cirrhotic patients. So this is a very precise way of defining clinically MAFLD-associated cirrhosis. Next slide. The third important advance that was done by the paper in Journal Hepatology is to recognize that patients with this new entity called metabolic fatty liver can also have another cause of liver disease. And since the diagnosis is no longer exclusionary, you can call the patient of having a mixed cause of liver disease. So for instance, if someone has all the criteria for MAFLD, but it happens that he also drinks significant amounts of alcohol, or has a viral infection by hepatotropic viruses, or has some other form of chronic liver disease, this new nosology allows you to classify the patient as having MAFLD plus a coexisting cause of chronic liver disease. So this truly reflects the reality of what we see in clinical practice, instead of turning a blind eye to the presence of MAFLD in these individuals. Because what happened before is that most of the time people said, oh, okay, alcohol, I don't look further for NASH, it's alcoholic liver disease. Hepatitis C plus obesity, diabetes, I don't care about metabolic risk factors, is hepatitis C. Well, in fact, no. Patients can have both, and it might be that the liver is damaged more if you have both diseases. A fourth important advance in the diagnosis is the classification of fatty liver disease based on the initial insult. So most of the time, we called insulin resistance associated NASH, we called it primary NASH or primary NAFLD. Because we recognize that most cases are indeed related to insulin resistance. But as you all know, there are other circumstances where the patient doesn't have any metabolic dysfunction, yet he has steatosis. So there are some other causes that we used to call secondary causes of NAFLD. This new classification simply says that we should say either MAFLD or alternative causes of fatty liver disease. And those are the ones that you know: celiac disease, medications like methotrexate, corticosteroids, cyclines, disorders of lipid metabolism, Wilson's disease, all these lipodystrophy, lysosomal acid lipase deficiency, all these diseases, they have no metabolic substratum, but they do induce fatty liver. And it's important to call them the right name. And that would be, so alternative causes of fatty liver disease, which are so independent of metabolic dysfunction. Next slide. So the final change that this methodology introduces is the fact that if you consider the fatty liver disease as a whole, you have to look at two particular things, which are the activity of the disease and the stage of the disease. So basically activity and fibrosis. And this will be developed by Pierre Bedossa later. But until now, if a patient had inflammation and liver cell injury together with steatosis, we call that steatohepatitis. And here the authors propose to have a wider definition, a wider description of the histology. Instead of saying steatohepatitis, yes, no, simply saying fatty liver, and then grading the activity and staging the fibrosis pretty much the same way we're doing with the metavir in a chronic viral hepatitis. So in the author's view here, the term steatohepatitis should be abandoned in favor of a full description of the activity grade and the fibrosis stage. And that would be MAFLD activity X, fibrosis Y. Once you have done that, of course, there will be time based on the scientific advances to see whether there is further heterogeneity in terms of the different factors that can impact the phenotypic expression of NAFLD. Now, not everybody agrees with that, and some people say that we should still keep the term steatohepatitis. There are several reasons why that should be, but one of the most obvious reasons is drug development. Drug development involves the agencies taking position for a certain segment of the population that needs pharmacotherapy, and thereby directing the clinical trials in that particular population. If you take the term steatohepatitis out, then it means that it becomes more difficult to precisely identify with a simple name these patients that are in need for pharmacotherapy and which should be included in these clinical trials. So this issue is not entirely settled yet, and I think it will be further debated. Next one. So you can see here in this small cartoon the different changes that take place. It goes much further than just changing the name from NAFLD to MAFLD. It is the recognition that you can have a whole spectrum of disease based on the relative impact and weight of metabolic risk factors, alcohol consumption, and at the end of the spectrum, you can have clear-cut situations like no NAFLD at all, like cryptogenic disease, or purely alcoholic liver disease. But in the middle of that, you have a lot of patients with varying degrees, variable degrees of alcohol consumption. And maybe the best way, instead of just saying black and white, is to simply state and describe the amount of alcohol so that you sort of know what role alcohol plays in this patient. And the same for the distinction steatosis versus steatohepatitis. A different way to say that is to get rid of that distinction, but simply state how much there is inflammation and how much there is fibrosis. Next slide. So this, I would finish by saying that it is time for the nomenclature to change. There are significant shortcomings of the current nomenclature. It is possible that by adopting a more appropriate nomenclature, it will help us to better identify disease subtypes, to better identify targets for therapy, conduct clinical trials, and therefore relieve the burden of the disease. But it has to start somewhere, and probably a good way to start is to put in order the way we call the disease, and to recognize the fact that in real world, people are not black and white, and there is interference between these different causes of liver disease. That is one thing. Now, having said that, changing the name of the disease is a very complicated process. It is not done by just a group of individuals, even if they're experts, even if they're from different countries, even if they agree between themselves. It is not enough to change the name of the disease. So therefore, the papers that I've commented upon, the gastroenterology papers, the Journal of Hepatology paper, are just the beginning of the process. They're a very good starting point because they explain what's wrong and they systematize, they propose a nomenclature. But by no means is this final. And what needs to be done now is that the scientific societies set up a panel of experts that start working on these different issues and see what are the consequences of a name change in all dimensions, from clinical care to research to drug development to reimbursement to epidemiology, healthcare providers, everything. What are the consequences of that? And then with a very large number of people trying to vote and to once these problems have been identified, either decide it's too early to change the name, or to decide that if name change is needed, maybe then propose different ways to do it, have people express their opinions, vote on that, have a really interactive process, what is called the Delphi method, where it goes back and forth on several rounds of voting. And after that is done, a vote at the level of the scientific societies will be useful. And if that vote is in favor of a particular name, then it will be published in a joint statement by the scientific societies, and then hopefully the name will become common practice. So we still have to wait. There's still a lot of work to be done. It doesn't mean that starting tomorrow we should call everybody NAFLD, but I think the papers by Jacob George and Mohammed Eslam are a really useful wake-up call and a really smart way of presenting the data that tells us that there is an urgency to abandon this 30-year-old terminology we have been using ever since. Thank you very much.
Good afternoon, and thank you very much, Professor Leila, for the kind invitation. It's a great pleasure to be there, even remotely. The title of my talk is Why Liver Biopsy is Important. Of course, as I am a pathologist, my answer is clear. It is important. But before that, let me underline some of the limitations of the liver biopsies. Of course, the first one is that Nash or NAFLD is a worldwide, very common disease. And of course, all these patients could not get a biopsy. So it should be clear to everyone that biopsy is not a screening tool. The second issue is that biopsy has obvious limitation. And I think that everybody recognizes that it is an invasive procedure. There is a risk of sampling error. This is a costly procedure that needs some resources. You should argue that there are non-invasive tools that may replace biopsy for NASH diagnosis, but I will describe next how there are limitations in this non-invasive tool. And finally, you can argue why to diagnose this or to characterize NASH when there is no drug available. That is a good point. Now, let me rather focus on why liver biopsy is important in NASH. First of all, the definition of NASH is based on histology and only on histology. And this is one of the rare chronic liver disease where the definition is based on histological criteria. So if you want a diagnostic of NASH, you need to have the histological proof and you need to have a biopsy. As Vlad said in his excellent talk, biopsy is also important to characterize this patient with non-alcoholic fatty liver disease in terms of grading the activity and staging the disease. Because of course, this will predict prognosis. We have, of course, non-invasive tools, but so far they are only surrogate. There are good non-invasive tools for assessing steatosis, for assessing fibrosis, but they are of unacceptable accuracy for the diagnosis of NASH. Therefore, non-invasive tools should be considered as a process that could help to select the patient that will have a biopsy. And finally, if you want to include your patient in those phase 3 clinical trials that are running around, it is mandatory by the regulatory authorities to have a biopsy, in fact, 2 biopsies for eligibility and for assessing the drug efficacy. So let me go 40 years before and just a little back about the classification. Jürgen Ludwig, who was a professor of pathology at Mayo Clinic, defined first a group of patients which was called non-alcoholic steatohepatitis. This patient has a biopsy which looks like acute alcoholic hepatitis, but they did not drink at all. So this non-alcoholic fatty liver disease, which is the whole group of the disease, has been spared in 2 groups. First one, which is a benign form, which is simple steatosis or non-alcoholic fatty liver. and the form that is supposed to be more severe, which is steatohepatitis, NASH, that everybody talk about NASH, and this comes from that. This is a typical disease which is based on the association of histological pattern. And on this slide, even if you are not an expert pathologist, you can see the typical feature of steatosis, for example, there, of ballooning, and you can see here these round clear cells, and of inflammation, and you can see here foci of inflammatory cells. So when you have these three features, you have the diagnosis of NASH. In addition, there are other features that are very evocative, such as this typical perisinusoidal pattern and the topographical location around zone 3. So why is it important to recognize within the group of non-alcoholic fatty liver disease a subgroup of NASH? Because there are strong arguments or even proof that steatohepatitis drive the patient to fibrosis, cirrhosis, and hepatocellular carcinoma. So it's very important to isolate them. But of course, this is not so simple. Why? Because this simple scheme can be debated. First of all patients that have steatohepatitis probably does not come to a baseline of steatosis. Some can go directly from nothing to steatohepatitis. Second, this is a very dynamic disease, and steatohepatitis or NASH come and went. So it's very difficult to have such a dichotomous classification in a dynamic disease like that. So, then, when you define two groups within a big group, then there are borderline cases, and how can you describe them? This is very common and very difficult. Again, there are other complications, other situations where some patient will develop fibrosis directly from steatosis. This is a short number, but there are some of course, well-known cases. What is well-known also is hepatocellular carcinoma, will not develop always from cirrhosis. And what is much more important is that, again, not only steatohepatitis, but fibrosis is the dynamic lesions that can come and went. So as you see, it's not so simple. And this dual approach, steatosis versus NASH, does not fit very well with such a complicated scheme. So if you now go back to your microscope, what you will recognize is that there are three components: the steatosis, the activity, and the fibrosis. So from a pathophysiological point of view, steatosis is a marker. Vlad talked about that. This is not very highly specific because you can get it in other conditions, but it needs to be there to have, by definition, non-alcoholic fatty liver disease. Activity is a driver. This is a lesion that will allow the liver or will degrade the liver to fibrosis, which is, of course, the killer. Let me go briefly about the different components. Steatosis, it's obvious to recognize. And as you can see here, it's a very homogeneously located lesion. You have here central vein, portal tract, and portal tract. And you see that this central vein, this steatosis is located always around central vein. So it's a marker of the metabolic syndrome. Also, again, it's not highly specific, but it should be there. Activity is a driver. And activity, in fact, is composed of only two features. The first one is inflammation. Those cells which are mononuclear cells, lymphocyte, macrophages, and the ballooned cells that you can see, for example, here. And when you put them together, you have the lesions that will drive the liver to fibrosis. This is quite different to what the concept of NAS or NAFLD activity score, which include steatosis within activity. There is now strong proof that it does not belong to the activity. And we have defined in Europe the SAF system for steatosis, activity, and fibrosis. Steatosis and fibrosis are similar to what is defined within the Nash CRN, but activity now is just made of the association of ballooning, quoted from 0 to 2, and lobular inflammation, quoted also from 0 to 2. So it's different and probably more relevant for definition of activity. And finally, fibrosis, and you have here fibrous septal nodulation. And this is a killer because there are many studies which have shown that the stage of fibrosis is correlated to the overall survival according to the index biopsy. I just quoted 2 of the studies, but there are several others which have shown that fibrosis is the only independent predictive marker of the overall survival. So liver fibrosis is a major prognostic factor. It is staged from 0 to 4, but it is an oversimplification. And again, with a European group, the FLIP group, we propose to define fibrosis from 1 to 6. We made a little bit of change. We put together all the stage 1 into a single one. We define differently stage 2, but more importantly, we divide stage 3 and 4 into different grades. So we have now a more granular scoring system, which go from 0 to 6. And the interesting issue is that you could expect that increasing the number of stages will diminish the reproducibility between pathologies, but it is the opposite. And using this scoring system, and because the different stages are very accurately defined, the inter-observer variability is quite as high as it is for the Nash CRN from 0 to 4. So those said, I just want to insist on what Vlad said also, that there is many shades in non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is a chronic liver disease with activity and fibrosis. If you took, for example, this biopsy where you have very mild activity and very mild fibrosis, in these two-dimensional schemes, you have here in this place this biopsy. This one is another biopsy where you see a lot of activity. There is many ballooned cells, there is a lot of inflammation, but there is very mild fibrosis. So this is where you can put it, a lot of activity, but mild fibrosis. This other biopsy is a biopsy with advanced fibrosis, but quite no activity. And you can put it there. And finally, this one with a lot of fibrosis, cirrhosis, and a lot of activity. And you put it there. So as you can see with this adaptive classification, you can put all the biopsy and all your patients in a scoring system that allow to define very accurately what is the activity and what is the fibrosis. And this is very relevant because when you are working for biomarker discovery, having these two scoring system completely different and not only the Nash, no Nash, then you can work on biomarker for disease activity if you use the horizontal bar or the biomarker of fibrosis using this bar. It's also important for patient management and follow-up. Again, when you just have Nash, no Nash, which one do you choose? Now with this associated two-dimensional scheme, you can define 3 zones. Those ones which have mild activity, mild fibrosis, which are patients that have to be released. These patients which have high activity and or high fibrosis, and these are the patients at risk that this patient to be treated. And you have the intermediate group, which are the patient to follow up. And finally, this scoring system is also relevant for personalized treatment because depending on where you are, if you are in this area, of course, you can expect that in the future, you will have treatments which are more active on inflammation. And this is what for this patient, while this patient, which have high fibrosis and low inflammation, can probably benefit more of antifibrotic. So changing this paradigm makes the things probably much easier. So my take-home message are the following. Liver biopsy is the gold standard for the diagnosis of NASH. The classical definition of NAFLD by category is subject to evolve toward a more adaptive classification. NAFLD is just one other chronic liver disease, which, like other and, for example, chronic hepatitis, should be graded for activity and stages for fibrosis. Fibrosis, of course, is the main prognostic determinant in NAFLD. And don't forget that it's a very dynamic disease. Non-invasive These two should be used maybe to follow up histological changes, because you cannot repeat commonly the liver biopsy. And of course, so far, drug development requests liver biopsy. And with that, I thank you for your attention.
Now, I'd like to invite the Professor Venâncio Alves to introduce Professor Cláudia Oliveira to present the case report. And after that, we open for discussion. There is many questions in QA here. I'm trying to answer someone here, but others, I'm going to talk to both of your speakers to answer these questions. Professor Venâncio.
Thank you very much, Professor Leila Beltrão, for hosting this meeting. Very interesting. Thank you, Professor Ratziu and Professor Bedossa. Excellent talks. And it's my pleasure to introduce our associate, Cláudia Oliveira, who has been working at the University of São Paulo for many years now, always devoted to the study of metabolic disease. So let's go ahead, Cláudia, it's with you.
Hello, everyone. I would like to thank you, Leila, and Professor Vlad Ratziu and Professor Pierre Bedossa. Vlad, I would like to thank you again, for your help to improve our research in Nash, and you spend more than years and we've published papers. Thank you so much for your help.
For nothing, it's all your work.
Nós vamos apresentar em português, então nós vamos apresentar um caso de esteatohepatite num paciente com uma fibrose não avançada, e era um paciente que tinha 73 anos, nascido aqui em São Paulo, né, e que tinha sobrepeso, diabetes e hipertensão desde 2001, então ele tinha o diagnóstico de NAFLD também, segundo a nova definição. Esse paciente, ele tinha já diabetes e sobrepeso de 2001, mas ele chegou ao nosso ambulatório em 2006, né, em que foi observado, então, ultrassom com uma esteatose acentuada, aumento de aminotransferase gama-GT maior que uma vez o nível normal, ele não usava álcool e era tabagista. Todas as outras causas de doença hepática foram excluídas, ele usava atenolol e glicazida, e esse paciente, quando chegou ao nosso ambulatório, ele foi orientado à perda de peso, à prática de exercício, ao melhor controle das comorbidades, adicionou-se metformina e losartan, e durante 6 meses, esse paciente, quando retornou, ele não seguiu, né, as medidas de mudança de vida, como a maioria dos nossos pacientes. A enzima melhorou, mas não normalizou, e porque ele tinha mais que 3 critérios da síndrome metabólica, e na época não tinha fibroscan, esse paciente já foi direto à biópsia, e essa biópsia mostrou, então, uma esteatohepatite, né, com esteatose macrovesicular, com infiltrado inflamatório, e que na coloração de Masson nós observamos uma fibrose grau 2, né, da veia centrolobular, até não chegava ao esforço portal, então era no meio do lóbulo e deu um grau 2. Esse paciente, então, de 2006 a 2009, ele ficou em acompanhamento conosco, nós acabamos de fazer anualmente o ultrassom nesses pacientes com esteatohepatite. Em cirrose a gente faz a cada 6 meses e nos não cirróticos a gente faz anual. Esse paciente aumentou de peso, ele continuou com elevação das enzimas hepáticas, embora a função hepática dele era completamente normal. E no ultrassom de 2009, observamos então um nódulo de 3,2 centímetros no ultrassom, no segmento 8, e quando confirmamos com tomografia, observamos o wash-in e o wash-out, né, na fase portal, que confirmavam carcinoma hepatocelular. Esse paciente realizou-se a ressecção nesse paciente, porque ele não tinha cirrose, ele não tinha hipertensão portal, e foi observado, então, um aspecto que a gente chama de subtipo esteatohepatítico, em que dentro do tumor a gente observa a esteatose macrovesicular, balonização, inflamação, né? E isso faz parte também do número de casos de uma publicação de uma aluna nossa, que o professor Venâncio vai comentar a seguir, mas o que se identificou nesse caso foi o subtipo esteatohepatítico. Só para dar um segmento nesse paciente, então, após a ressecção em 2009, em 2011, ele teve uma recidiva do carcinoma hepatocelular, só que agora multifocal, fez uso de sorafenib e teve uma sobrevida de 38 meses após o uso do sorafenib. Então, eu queria chamar a atenção, na verdade, a gente trouxe um caso, né, que se encaixa tanto no NAFLD como no MAFLD, de um paciente que tinha carcinoma hepatocelular sem a presença da cirrose. A gente começou esse estudo, então, aqui com o Vlad, né, no estudo FLIP, em que também já observamos em 42 casos, essa casuística junto com a Universidade do Rio Grande do Sul, do professor Mário Reis, nós observamos que existiam 3 casos já com fibrose grau 2 e 2 casos com fibrose grau 3. E mais recentemente, com o trabalho da nossa aluna de doutorado, a Priscila, nós observamos de 423 pacientes, 21 só se encaixavam, então, no diagnóstico, no critério de esteatohepatite HCC, estudamos 35 nódulos desses pacientes e, só para vocês novamente ratificar, 42% desses pacientes tinham fígado não cirrótico. Então, por isso que a gente trouxe esse caso para chamar a atenção. E aí o professor Venâncio pode comentar os dados histopatológicos.
É muito interessante, cada vez mais, nós voltarmos à importância do anátomo patológico no estudo do câncer. Houve um tempo, e agora esse tempo está passando, em que não se biopsiava os nódulos hepáticos suspeitos de carcinoma hepatocelular, com uma perda enorme da oportunidade de se saber se é mesmo um carcinoma, se esse carcinoma é de tipo hepatocelular, e agora nós conseguimos saber subtipos. Tem pelo menos 13 subtipos propostos, buscando-se agora as correlações de uma parte com perfis genéticos específicos e de outra parte características etiológicas e significado clínico diferente. Esses 3 casos apresentados da tese da Priscila mostram apresentações consideravelmente diferentes. No contexto da esteatose, no contexto da cirrose, nódulos com ou sem cápsula, eles têm significado diferente. E o padrão histológico característico é balonização, maloridente, fibrose intratumoral e inflamação intratumoral, de modo tal que cada um desses achados pode ser visto na neoplasia e muito provavelmente terá um significado. Se não houvesse outro dado, a presença de esteatose e balonização reproduz o padrão esteatohepatítico. E vários dos casos vistos na tese da Priscila, carcinoma hepatocelular no contexto de doença metabólica, nós estamos vendo apresentações de carcinoma hepatocelular com infiltrado linfocitário denso, muito possivelmente abrindo caminho para a perspectiva de uso terapêutico dos inibidores de checkpoint da resposta imune. Finalizando, esses 2 trabalhos, esse do Histology and Histopathology, saído agora em julho, e o trabalho com o grupo português da Universidade do Minho, recém-preparado, mostram perfis imunistoquímicos diferentes. E esses perfis imunistoquímicos, de alguma maneira, mimetizam o perfil genético que começa a ficar bem caracterizado em 4 ou 6 subgrupos moleculares que podem ser subdivididos em perfil inflamatório, perfil proliferativo mais acentuado ou perfil de células progenitoras. Então, algumas dessas lesões expressam citoqueratina 19, significando padrão de células progenitoras. Outros subgrupos de carcinoma hepatocelular são mais positivos, mais de 10% de células expressando Ki67, e outros ainda expressando proteínas relacionadas a distúrbio metabólico, a fenômeno de Warburg. E Os carcinomas hepatocelulares variantes steatohepatítica têm pouca participação de células progenitoras, pouca participação de atividade proliferativa e acabam sendo classificados nos grupos de atividade inflamatória. Então, nessa classificação muito recente, coordenada pela Jéssica Zuckman-Rossi, da Universidade de Paris, como os nossos convidados de hoje, subclassifica nos perfis moleculares, e esse perfil esteatohepatítico seria do grupo mais relacionado à baixa proliferação com atividade de vias metabólicas com ativação da via JAK-STAT. Consideravelmente diferente daqueles outros hepatocarcinomas muito mais proliferativos, muito mais associados a vírus das hepatites, como por exemplo. Então, esse era o que nós gostaríamos de apresentar. Cláudia, por favor, conclua. E a síndrome metabólica ficando, então, nesse grupo de padrão inflamatório e, muito possivelmente, de melhor prognóstico, considerando, quando comparados com as outras formas de carcinoma hepatocelular.
E só ratificando isso, além da literatura, a gente tem um trabalho com o professor Louvet, em que, novamente, 53 casos de um estudo internacional, nós observamos isso que o professor Venâncio falou, que existem classes proliferativas e não proliferativas, e provavelmente a doença metabólica está na classe não proliferativa. Então, eu queria agradecer a todo o grupo, né, do São Paulo Liver Cancer Group, né, e que a gente trabalha, e ao Vlad novamente, porque me introduziu nesse aspecto relacionado ao carcinoma hepatocelular. Eu venho estudando Nash há muito tempo, mas o carcinoma hepatocelular foi um convite dele para entrar no estudo clínico europeu, e por isso a gente iniciou esse estudo aqui na universidade. Acho que é isso, Leila, e eu acho que poderíamos já passar para as perguntas.
Muito obrigada, Cláudia e Venâncio. Ótima. Oh, sorry, I have to speak in English. Sorry. I think it's very nice, excellent case, Cláudia and Venâncio. I will open to discussion, and I do like that you and Venâncio coordinator. There is many questions here in the QA, and also if I'd like invited someone to share the platform here, and could ask by himself, like Professor Mário Reis, Professor Parisi. There is some question that I could start to do in some ones. For example, Cláudia and Venâncio, could you see the questions from the QA from the screen? Or could you start to do some your question to Vlad and Bedossa? Some ones I just answer from the Q&A. Yeah. I think it's better you ask first Professor Pierre and Professor Vlad to answer some questions from you.
Okay, Vlad and Professor Pierre, how can we improve the new definition, including liver biopsy in some points? Because if in clinical trials, you need liver biopsy. How can we improve NAFLD? But do you think that it's important to include liver biopsy? And what the name MASH or continuous MASH? What is your opinion? Vlad and Professor Pierre.
Pierre, you want to answer, or should I go first? No, I think the definition should not include histology, because the reality is that most of the people don't do liver biopsies, and the definition needs to be useful in most cases. So since liver biopsy is only done by very few people in this disease, mainly people in specialized hospitals or doing research, I think the definition should be as clinical as possible. And the progress will not come from including histology. The progress will come from identifying special forms of NASH. Do we have reason to believe that this particular form of NASH has a different etiology? Then we should include in the definition something related to that. So when we will know more about genetics, microbiome, different causes, proteomics, things that can help subcategorize NASH in different buckets, then we will make some progress.
Maybe I can add few things about Vlad. I think that indeed we don't need to include histology in the definition, otherwise we will be in the same trouble that we are now because there are so few biopsies. But of course, biopsy should stay in the armamentarium of the hepatologists because, of course, you can expect that we will define the role of microbiome, etc., etc. But so far, what we need is assessing fibrosis. It is assessing activity for the development of trials. So biopsy will stay for a while, I think, in the area, and will be very useful, I think, to assess and to foster the drug development. So far, the only endpoint for drug development is clinical outcome, but it takes a very long time. So the biopsy could help as we call interim analysis, and for that we need the biopsy, of course.
There is one question here from Professor Edson Parisi from São Paulo that he asked to say first for Professor Bedossa that is very interesting, the schedule for treatment that you mentioned in your conference, and he would like to know what's the best test for proposing the clinical practice.
Well, if you mean for a diagnosis of NASH, the best non-invasive test, this is what you're thinking about?
Yeah, no, he would like to know how could you think to test the new proportion in clinical practice?
Well, I think really it's more a question to Vlad, but I would say that we should keep in mind that there are risk factors, diabetes and obesity, etc. There are non-invasive tools which are easy to perform, for example, FibroScan, which is very good. Of course, there are others which are much more sophisticated, such as MRI PDFF for steatosis. And when you get this, with of course increase of transaminases, etc., when we get all these arguments, then you have to think of a biopsy at the end.
And Professor Mario Reis asked to you as well if there is any space or utility in clinical practice to quantification the liver fibrosis.
Well, I think that quantification of liver fibrosis should be done on the biopsy. It should be based on a semi-quantitative evaluation like we are doing now. There are some very sophisticated tools that could quantify by morphometry, for example, the amount of fibrosis. But it looks to me a little bit complicated and probably not so clinically useful. So assessing fibrosis with non-invasive tool first and then making a biopsy and scoring with a semi-quantitative score is of course very important because this is prognosis.
Okay.
Professor Leila, Dr. Chiara from Rio de Janeiro asked Vlad about what is the relevance of PNPLA3 in treatment and prognosis in NAFLD.
What is the relevance of being?
PNLP3, polymorphism.
Oh, okay.
Yes.
PNPLA3.
Yes.
The very important It is the only marker that has been consistently found to be associated with severity of Nash. And you know that because you also did some studies with genetics. What is really interesting now, it is a susceptibility gene for steatosis, but also for inflammation and fibrosis. But what I find most important is that also it seems that it increases the risk of liver cancer pretty much, probably by a factor of 10 or so. So PNPLA3 could be also a good marker of susceptibility to liver cancer. If this is true, maybe a patient like the one you have shown could have been monitored differently, and maybe the diagnosis could have been made at an earlier stage. Maybe not. It was striking in your case that when you diagnosed liver cancer, it was only 3 centimeters. So that is small. You can't do so much better than that, especially in people who don't have cirrhosis. Normally, there is even no indication for monitoring. And then once a patient has a cancer, his risk of recurrence, even after a curative treatment, is high. So maybe then you can follow him very closely. PNPLA3 at that stage might not have changed much, but it could change the way you follow people that don't have cirrhosis. If they have PNPLA3, the mutation, then maybe they should have more intense monitoring for liver cancer. But it's not easy because it's so many people out there and you can't do ultrasound in all of them. So for the moment, the PNPLA3, I don't think it is a big clinical relevance, maybe for liver cancer, but we need more data to stratify patients.
There is one question from Professor Luis Freitas from Bahia, Salvador, to Professor Pierre. Congratulations, Pierre, he said to you, for your outstanding lecture. And I would like to hear from you, when you sign out a case as steatohepatitis, whether do you state it as alcoholic or non-alcoholic? If so, which morphological clues can help us to differentiate between them?
It's a very good question. Thank you, Dr. Freitas. Theoretically, there is no difference when you are looking to severe ASH and severe NASH, but practically, when there are many mallory bodies, I think that Venâncio should also give his opinion, but when there are many mallory bodies and when there are a lot of polynuclears, this is a good sign that there might be some alcohol associated. But again, it's just part of the puzzle, and this usually when I have this feature, I suggest that there is also the role of alcohol in the development of the disease, but as Vlad said, this is often associated.
Cláudia, there is some questions from Professor Elma Coutrin from Salvador, Alex Vianney from Aracaju. Could you help me to ask some questions as well, and Professor Venâncio? There is one from Roberto Blasbach. What is the role of liver multiparametric evaluation by magnetic resonance imaging in the diagnosis and monitoring of patients with NAFLD?
Vlad.
Yes, the question was about how do you monitor NAFLD?
Yeah, by using RMI.
MRI?
Yeah.
Okay, so MRI, at least in France, is not used for clinical indication, clinical practice, only used for trials. When you do MRI, you can measure either the amount of fat, PDFF, or you can do MRE and measure elastometry. Very few centers have elastometry. More centers now have PDFF. It is very useful for research and clinical trials, but not so much for everyday practice. In everyday practice, if you try to implement diet and lifestyle changes, it is indeed important to measure if steatosis goes away. So you can do ultrasound and see that there's no more steatosis if the patient lost weight. But it's true that ultrasound is not very sensitive. So PDFF could be indeed a good tool because you quantify the percentage of fat, and then if it goes down, it means the patient lost fat. But it is very expensive to do in clinical practice. And although it's very precise and quantitative, for the moment, there are no clinical applications for that. In clinical trials, it's very important. Many of the drugs we're testing are measured by their ability to reduce liver fat, and this can be measured precisely with the PDFF MRI.
Claudia, could you share with me and Venâncio for other questions in the screen?
Well, there is a debate on moving or not to methyl. Should we report in our diagnosis the term already, or what should we wait? Because in 2012, a group of pathologists, I'm included, sent the point for not mentioning cirrhosis anymore. We still do diagnose of cirrhosis every day, but from that point on, we took attention on the point that cirrhosis are quite different one from another. So it was quite helpful putting this quest. And once again, I feel very much that you are in the correct way, that you should subdivide the metabolic approach in diabetes or overweight, even plus alcohol. And so how should we address the matter? To put metabolic and then NAFLD, put as synonymous? How should we do the reports in pathology, in clinical grounds, and so on?
For the pathology, I don't think it changes anything. This is a clinical diagnosis. The pathologist describes what he sees. And he doesn't have to say if it's metabolic, if it's due to another cause. Pierre just told you it's very hard to tell alcohol from no alcohol. So the pathologist has to simply address the pathological lesions. MAFLD or NAFLD, that's an issue for the clinician. Now, 2 hours ago, we had a visio conference with several people from EASL and a few people from ASLD regarding MAFLD. And the Americans are not very happy about this move for different reasons. One of the main reasons is that they do not consider that the name change was truly consensual. And we sort of took the decision that we will initiate through the scientific societies a whole process that will result in maybe in a name change. But before this process is over, we should be very careful about using the new term. We should be very careful. And for instance, if you send a paper with MAFLD to hepatology, I think they will not like it. So you have to be careful because we don't know what will come out of this. And what we need is something that is official by the scientific societies. So for instance, you know, primary biliary cirrhosis, okay? There was a name change a few years ago, and the name was changed to primary biliary cholangitis. But the process that resulted in the name change was organized by the societies, a lot of work, a final vote between the societies, and then it became official. I think we should wait for Nash for the same thing. When I say societies, I mean EASL ASLD, but we decided that we will invite representatives from APASL and that we will invite representatives from ALEG. Brazil is part of ALEG, right?
Yes.
Yeah.
Yes.
Yeah.
So once this committee starts working, I think it will be important to wait for the final conclusions before officially changing.
There is another question, Vlad and Pierre, for you. That's from Cristiane Vilela from Rio de Janeiro. She'd like to know if you recommend to repeat a liver biopsy in patients with NAFLD in clinical practice, or if you just follow them with a non-invasive test.
So we follow them with non-invasive tests for sure. Sometimes we repeat the liver biopsy, especially if we have the demonstration that non-invasive tests are going up. Because then you want to confirm if there is progression of fibrosis. So sometimes we do that. We never repeat the biopsies less than 5 years apart in regular practice. Although for trials, sometimes you have to repeat them earlier. But we give the patient at least 5 years. If you see that the metabolic condition got worse and the fibrosis markers also escalated, then probably a liver biopsy would be a good thing to demonstrate if yes or no there is progression.
Claudia and Venâncio, do you have any more questions from the QA or?
The last question about from Alex Vianney from Brazil, and he asked about how, Vlad, you follow the patient without cirrhosis. If you do ultrasound each year, or how do you follow?
For liver cancer, I don't do anything because liver cancer in non-cirrhotics is very rare, and there is no recommendation to do monitoring because it's so rare, it is not cost effective. So in a patient that does not have cirrhosis, I follow the recommendation. I don't do ultrasound. If the patient, of course, if he has cirrhosis, I'll do the regular cirrhosis monitoring. If the patient had already, like your case, a nodule, then of course you have to monitor. But other than that, I do not do it. I monitor the patients for fibrosis progression with a FibroScan and maybe one biomarker. I monitor the patients for the metabolic condition. So weight, waist circumference, I measure all the time. Hypertension, diabetes, HbA1c, lipid levels. I monitor HOMA levels and liver tests. That's all.
Claudia and Venâncio, there is one question from Professor Elmo Coutrin from Salvador. Could you do it, because our time, I just stayed a couple of minutes because everybody is very excited for the excellent presentations, but you have time to finish this webinar.
Elma asked about the change of the new definition about the secondary cause of NAFLD. What about, do you think?
So I think we have patients that don't fit the metabolic profile. And then you wonder, why do they have liver fat? It's very frustrating. And it is very important that we learn about the secondary, the alternative causes of liver fat. It's very important. Sometimes it's genetic causes, sometimes it's other diseases. But it's very good to be able to give the patient a diagnosis. And people are frustrated when you tell them they're liver fat. They are not overweight, they don't drink alcohol, so why do they have liver fat? So that's why all these secondary causes are very important to demonstrate. I know in Brazil, and Helma Cotrim published on this, there are toxicants from the petrochemical industry that can cause steatosis or steatohepatitis. But there are also other causes like celiac disease, like lysosomal acid lipase deficiency, which is now very easy to diagnose on a blood drop taken non-invasively. There is also hypobeta-lipoproteinemia, you have lipodystrophies, you have, of course, Wilson's disease. It is important to have a catalog of all these other causes, because you run it occasionally into patients, you don't understand why they have liver fat. And also, I wanted to say something, I know Claudia will like that, is about intestinal bacteria. Because there have been publications of people in China that have liver fat and they don't have any cause, but they have high levels of alcohol in the blood. And it is not explained by alcohol drinking. It is explained by a proliferation of some species of Klebsiella that produce alcohol. And that alcohol then goes to the portal vein to the liver. And they demonstrated very nicely that that particular microbiome can induce fatty liver if you transplant it into mice. And it might be that some people that don't have the regular metabolic risk factors might have some bacteria that produce large amounts of ethanol, and that could explain the fatty liver in these people. So there's many secondary causes, and it's important to know them.
Okay, I think the time is,
So
I have to close, unfortunately, but I'd like to say thank you very much indeed for Vlad and Pierre to join us, and special to Cláudia and Venâncio. And also I needed to say that many questions will be answered for our organization. And I'd like to say my congratulations for my team as well from my university that share and have outpatient clinic. Some of them is young doctors that doing some research as well. Is a coordinator for Dr. Samia Fernandes and Fatima Barreto, and all my team from the organization of these meetings, like Luciano Beltrão Pereira, Cláudia, Mario, and Venâncio in this as well. Thank you very much. I hope to see you on 8th of July for the new meeting. Is a transplant meeting with Professor Mario Hitton from the UK and Professor Rodrigo Viana from US, and a couple of expertise in transplant here, like Professor Ilka, Professor Luis Carneiro, and Professor Zé Wigens. Thank you very much indeed, and see you soon. Vlad, only
Bye,
bye, Vlad. Thank you.
Thank you very much for all, everyone. Bye-bye.
Thank you so much. Bye-bye. Stay safe.
Okay.